Topic for discussion is herpes zoster, varicella zoster virus. Herpes zoster is a dermatotrophic and a neurotrophic virus, which is a alpha herpes virus, one of the 8 human herpes viruses. And primary infection which is caused because of this herpes zoster is varicella, that is chickenpox, known to be the primary infection. On reactivation of this, which leads to varicella zoster infection or herpes zoster infection, also called as shingles. This herpes zoster infection is usually because of immune suppression, or usually seen in case of patients with immune compromising. In patients who are undergoing chemotherapy, any chronic immune suppression because of any grafting procedures, and in case of AIDS patient, and in senile patients who are very elderly patients, herpes zoster is most commonly seen. Post-herpetic neuralgia is one of the sequelae of this herpes zoster infection, which is a painful condition and a morbid sequelae of herpes zoster. Post-herpetic neuralgia is a neuropathy which is resulting from nervous system injury of central nervous system and the peripheral nervous system. Coming to the etiopathogenesis of varicella zoster infection, the primary infection of this varicella zoster is usually because of the respiratory route or by the direct contact. The primary infection, as already told, is varicella, which is nothing but chickenpox, where at the site of inoculation there will be multiple macules and papules leading to the pruritic lesions. This virus is usually cytopathic, that is, it can destruct the cell, and it is cytopathic to the epithelial cells, resulting in blisters and ulcerations. The normal incubation period of this virus is about 2 to 3 weeks. And the clinical features of chickenpox include a characteristic rash, especially on the trunks, less commonly on the limbs and the face. The lesions manifestations usually start as a macule, that is, initially there will be change in the color, which later transforms into a papule, which is nothing but a slightly elevated lesion, and then it will convert into a vesicle. Vesicle is a fluid-filled blister and turns into pustular form. This pustular form is pus-filled, and later this will fall off by necrosis and self-apoptosis. This will fall off and form a scab. This scab will later transforms into a scar, and sometimes this can have a lifelong manifestation. That means this scar can be present throughout the life also. Usually these spots are denser on the trunk and less commonly on the limbs, and also seen on the face region. Herpes zoster is a reactivation of this varicella. At the time of varicella infection, that is the chickenpox, the virus can remain latent within the ganglion, along the neuronal ganglion, and then by a phase of reactivation in case of immune suppression, they can develop into zoster infection, that is herpes zoster infection. This herpes zoster is usually characterized by pain followed by a vesicular rash, and this vesicular rash later develops into a vesicle which breaks down to form an ulcer. They coalesce to form an irregular ulcer, and later they form crustaceans. Normally, the important feature of this herpes zoster is that it takes form of a dermatomal or zosteriform distribution. That is, it is usually a unilateral distribution where whichever the ganglion is infected, for example trigeminal ganglion, it will take the path of that particular nerve path. So it is called as dermatomal or zosteriform distribution. Normally there is a typical or pathognomic feature of this herpes zoster infection where it will give a dewdrop like vesicles, that is, multiple small vesicles are aggregated at a place, and this gives rise to a formation of a dewdrop like appearance. The other associated symptoms in case of zosteriform, that is herpes zoster infection, includes malaise, low-grade fever. The lesions are usually pruritic, and they will have a maculopapular rash. There will be unilateral dermatomal distribution of these zoster infections, where a cluster of these vesicles will form, which are red in color, and they have these multiple vesicles will result in painful conditions on touch. There will be deep aching, burning type of pain in case of zoster infection. The burning type of pain is one of the pathognomic feature. Other areas that are usually involved are thoracic and lumbar dermatomes, apart from the trigeminal dermatomes. Usually these will heal within 2 to 4 weeks, and there will be scar or hypopigmentation at the region of this healing. There is other condition called as zoster sign eruption or zoster sine herpetae, where Without any rash, patient will only exhibit paresthesia. That is, cine eruption means without any eruption. So, zoster without any eruption or rash is called as zoster cine eruption or zoster cine herpetic. Normally, in about 20% of patients infected with this herpes zoster can exhibit facial palsy, and they also will have, sometimes they might also have this acute retinal necrosis. Post-herpetic neuralgia. This condition is also a sequelae of herpes zoster infection, and it is a severe morbid condition, and in these cases what happens is about 20% of patients usually have this post-herpetic neuralgia, and in those cases there will be pain even after 120 days of healing of this acute rash that is caused by the herpes zoster infection. The pain is usually lingering, stabbing type and very sharp, and the pain with patient will have this unbearable post-herpetic neuralgic pain. Other oral manifestations include herpes zoster in head and neck region usually involves a trigeminal nerve and the three branches of the trigeminal nerve, that is ophthalmic nerve, maxillary and mandible. In case of ophthalmic nerve involvement, the forehead, upper eyelid, lower eyelid and the bridge of the nose is involved. In case of maxillary nerve involvement, maxillary branch involvement, there will be the middle 1/3 region of the face is involved, and in case of mandibular nerve, from the tragus, the lower mandibular region, lower lip up to the mid half, that is only 1/2 of the face is involved. This is nothing but the dermatomal distribution of the zoster infection. And intraorally, the most common site is palate, and most of the times zoster infection also affects the keratinized mucosa. Extraorally, lip is the common site. Usually upper lip is one of the common sites. And other in the three of these branches, ophthalmic nerve is usually one of the commonest branch that is involved in case of zoster infection. Within the oral cavity, especially at the keratinized mucosa, it develops painful vesicles which are clustered. They break coalesce and form into irregular ulcers. In case of extraorally, these ulcers further the encrustations will be formed on these ulcers and they heal spontaneously after that. Coming to immunocompromised cases, that is such as in cases like pregnancy or in cases where the immunity is very low, like in AIDS or HIV conditions, in case of leukemia, etc. There will be in case of graft, in case of patients having these grafts, etc. In all such cases, the HZV, that is herpes zoster infection, is full blown and it takes a very aggressive course. Manifestations are very severe in these conditions. Other oral manifestations in immune compromised HZI infection is resorption and exfoliation of teeth, and there will also be osteonecrosis of jaw and bones. Ramsay-Hunt syndrome is one of the syndrome that can be associated with herpes zoster virus, where herpes zoster infection involves a geniculate ganglion. Here, patient exhibits multiple vesicles in the ear, that is external ear, and also Bell's palsy and loss of sensation in anterior 2/3 of the tongue. This constitutes the Ramsay-Hunt syndrome. Other complications that are involved in herpes zoster infection includes various systemic manifestations, which in case of untreated and in case of immunosuppressed patients, the complications include pneumonitis, optic neuritis, transverse myelitis, congenital limb defects, myocarditis, pneumonitis, etc. Coming to the diagnosis, apart from history and clinical symptoms, and most commonly a typical dermatomal or zoster-form distribution of herpes zoster infection, other investigations that will help us in identifying herpes zoster infection is viral isolation using cell culture. This is the gold standard. However, identifying a virus, culturing the virus is one of a difficult task. PCR and real-time PCR, that is polymerization chain reaction, is one of the best diagnostic aid which will help us in identifying herpes zoster infection. Other thing is that in serological test, IgG will be elevated in case of herpes zoster infections, hence IgG estimation can also be done. Coming to the management, in herpes zoster infection, symptomatic treatment, for example like pain control, supportive care, hydration, etc. is one of the useful method in controlling the disease condition, and ibuprofen is one of the preferred analgesic. In these cases, aspirin is usually avoided in case of herpes zoster infection because it can give rise to a syndrome called Reye's syndrome, which may be fatal in children. And Live attenuated vaccine is also available for conditions of herpes zoster to prevent herpes zoster infection. Other treatments for varicella zoster infection is acyclovir, where 800 milligrams for 5 times daily for 7 days can be given. Valcyclovir and famciclovir can also be given in the treatment of varicella zoster infection. In case of lesions which are on the dermatotrophic lesions, that is on the upper lip or on the lower lip or anywhere on the skin, topical 5% acyclovir cream can also be given. Coming to post-herpetic neuralgia, which is a painful condition where patient will have stabbing, gnawing type of pain along with burning sensation. In those cases, gabapentin, 5% lidocaine patch or topical capsaicin can be given. Opioids and tricyclic antidepressants can also be given. Botulinum toxin can also be tried in these cases where this toxin has to be delivered to the patient once in every 3 months, 3 to 4 months, depending upon the patient's response to the botulinum toxin. Thank you. Diphtheria. Diphtheria is one of the upper respiratory tract infections which has actually been abolished from other developing countries because of mass vaccination. However, it is still prevalent in countries like Russia and also in some of the South Asian countries too. As I told, diphtheria is one of the upper respiratory tract infection and the causative organism is Corynebacterium diphtheria, usually caused because of acute inflammation of upper respiratory tract because of the exotoxins that are released by this Corynebacterium diphtheria. Usually the primary manifestation is usually at the site of inoculation, at the site of inoculation and development of this bacilli. However, in the due course of time, this Corynebacterium diphtheria will release certain exotoxins and these will affect the heart and peripheral nerves, resulting in manifestations of heart and nervous system. The mode of transmission of this Corynebacterium diphtheria is due to droplet infection, and also it can complicate the infected skin lesions in patients who are misusing alcohol. The common sign of this Corynebacterial diphtherial infection is sore throat, where patient will have difficulty in swallowing and throat pain. Normally, these organisms are located within this pharyngeal region, releasing more number of exotoxins in due course of time, affecting heart and other nervous system tissues. Rarely, it also affects the conjunctiva and also the genital tract. Incubation period of diphtheria is usually about 2 to 4 days and it gives out various clinical manifestations. The most common clinical manifestation is bull neck or enlargement of lymph nodes at the area of pharyngitis, where patient will have enlarged lymph nodes, especially the submandibular lymph nodes, submaxillary and submental lymph nodes, giving an appearance of bull neck, where will be enlarged neck of the patient. Rarely patient will exhibit high temperature and tachycardia is one of the common features. In case of acute infection, there will be membranous tonsillitis, nasal and laryngeal skin involvement and also conjunctival infection. As a pathogen enters through the way of the droplet infection transmission via the nasal secretion or because of droplet, this pathogen will enter and usually resides in the pharyngeal region. It also can give rise to cutaneous diphtheria, myocarditis or heart failure when the exotoxins affect the heart, and pharyngeal diphtheria. There will be pharyngitis, hypoxia, pseudomembrane obstruction or fever and lymphadenitis. There will be toxic peripheral neuropathy also in some of the cases. Usually there will be a nasal discharge and that nasal discharge is usually blood tinged. In case of laryngeal diphtheria, patient will have continuous cough and this cough will have a typical hoarseness in it, and patient will also have dyspnea, that is difficulty in breathing. In some severe cases, there will be paralysis of the posterior soft palate, the pharynx, and this will result in regurgitation or difficulty in swallowing. In some cases, breathing is also difficult in those patients. Cardiac manifestations include arrhythmias and congestive heart failure. And the neural manifestations includes peripheral neuritis. These patients also have complications in the healing of skin wounds, where it results in non-healing skin ulcers. There will be paresthesia as the peripheral nerves peripheral neuropathy occurs and the patient will exhibit paresthesia. There will be acute circulatory failure and death in 10 days if patient is not treated for diphtheria. There is a characteristic diphtheric membrane which is a characteristic of this disease, where there will be thick, leathery, greyish green membrane on the tonsillar region, which will have a well-defined edge with the surrounding erythema. And this layer, which is a membrane, cannot be easily removed off, and on forceful removing it results in bleeding. It appears like wash leather, hence it is also called as wash leather membrane of diphtheria. And the diagnosis is most commonly the clinical symptoms and the characteristic wash leather diphtheric membrane will help in diagnosis. However, there are other diagnostic methods which will help us in coming to a final diagnosis of diphtheria. This will include complete blood picture, urine analysis. The primary thing is culture of bacteria, that is Corynebacterium diphtheriae, and the ultimate test is PCR, where it will test for a fragment of exotoxins which are released by this Corynebacterium diphtheriae. Other investigation is Schick test. This Schick test is used for antitoxin that is present within the blood and also the state of hypersensitivity for this diphtheric toxin. About 0.2 ml test toxin is injected into one arm and control is injected into other arm. And this is weighted up to 24 hours to 36 hours, and after this both the arms are being checked. If at all there is a red flush appears in the area of the test dose, then it is considered to be diphtheric positive. If at all there is no difference in both the hands, if both the arms are similar, then it can be taken as negative. Sometimes there will be pseudopositive reaction, that is allergic type of reaction, where both the hands will show an allergic reaction, that is red flush appears on both the arms. This is called as pseudopositive or allergic type of reaction. Sometimes there is a combined reaction also, which will be a true positive reaction, where the control arms show a pseudopositive and the test one shows a true positive reaction. Coming to the management of this diphtheria, first of all, if at all a patient shows diphtheric symptoms, it has to be isolated and notified to the local health authorities, because diphtheria is one of the conditions that is being tried to be abolished from the humans because of the DPT vaccine that is being continuously promoted through mass vaccination. So whenever a patient is being seen with diphtheria, kindly isolate and have to be notified to the health authorities. And diphtheria antitoxin for about 4,000 to 32,000 units, IV or IM can be given. First, you can also go with the test dose because few patients are allergic to this. And benzyl penicillin is drug of choice, where 600 milligrams 4 times daily for 7 days is given. Amoxicillin can also be given with 500 mg thrice daily for about 1 week. In case of complications such as I already told, there can be laryngeal paralysis and patient will have difficulty in breathing, dyspnea condition. In such cases, tracheostomy may be necessary. Immunization is one of the most important preventive measures to prevent this diphtheria. The DPT vaccine can be given in 3 doses, that is 0.5 ml, with 1 dose will be initial dose with 2 booster doses given at 6, 10 and 14 weeks of time. Erythromycin prophylaxis is also one of the preventive measures that has been given. Thank you.